crucial part of staying safe is for staff to implement simple, immediate de-escalation strategies to defuse a situation and keep staff and patients safe. Following an incident, staff need to be reflective practitioners, able to learn lessons, observe and analyse challenging behaviours and implement care strategies to prevent incidents from reoccurring. Staff also need to be self-aware by examining their own attitudes and behaviours and how verbal and non-verbal communication, body language and tone may contribute to making a situation worse. Sian was admitted to an orthopaedic ward after a road traffic accident with injuries to both legs. She has mental health issues and is extremely vulnerable, whilst also being aggressive and unpleasant to staff.
Nurse! Nurse! Slack! Nurse!
Do you mean you bleed me urgently?
Yes, it's Sian. She's having problems. This is Robert, Sian's doctor.
Okay, so the problem?
Yeah, we've had some issues with her before that required security.
Yeah.
We're kind of hoping you could
I
calm her down a bit.
Her? I can hear you.
Yeah.
Unhappy to be in hospital, Sian attempts to leave the ward and is found on the floor by healthcare assistants. Her initial response towards staff is one of aggression, distrust, vulnerability and distress.
Sam, I'm here to help you. I'm here to help you.
I've been ringing. Why haven't you been answering me when I've been ringing?
I don't know why the nurses haven't come.
Oh, I don't know why the nurse has been coming because you're stupid and you don't care about anything.
What we have to do is get you out of pain because you're clearly in a lot of pain.
Yeah, because you haven't given me anything.
Let's get you something. Let's get you some painkiller. That's why you were ringing, isn't it? So
Yeah.
I know you're due painkiller. So what I want to do is I want to get you back to bed.
No, you're not going again. You're not going to ignore me again.
I certainly won't ignore you.
Yeah, but no one's coming back to get me.
What I'm going to do is I'm going to get the painkiller. Then I'm going to come back, Sian, and I'm going to come and talk to you about this because it's just been such a horrible time for you, hasn't it?
Managing an episode of challenging behaviour relies on various de-escalation techniques. In this situation, a practical approach is taking the time to get to know the patient as an important tool to gaining trust and better understanding the reasons for the behaviour.
Sian, is the painkiller kicking in now?
I think so.
Yeah. You really hurt yourself, didn't you, getting off the bed and on the floor?
Yeah, because no one was listening to me when I was ringing.
Yeah. You know when I said that the nurses weren't, I didn't know where they were. They had actually wanted to come and help you.
Yeah, why didn't anyone come then?
Do you remember that over the weekend security came 7 times to see you? Now, we have a problem, don't we? In that we don't want...
Yeah, no, because no one comes.
Had you thought that might be because of the way that you were shouting at the nurses and at the doctors and security as well? I mean, it hasn't been easy for them either, has it? Now, you're in hospital. We actually want to look after you. So we've got to make a plan, Sian. We've got to make a plan.
A post-incident ABC, incident analysis chart, can be used to record and organise observations where practicable. This helps to spot behaviour triggers and patterns in order to identify appropriate and effective care strategies.
Have a plan and ask the nurses to come and see you, say, every hour, and just check up how you are, see if you want anything, see how you're doing, and, if you felt like it, have a bit of a chat with you. I mean, how would that be?
Be good.
When you're faced with an episode of challenging behaviour, then obviously the first thing to do is follow the guidelines. What I find in practice is that people don't trust their own instincts enough. And often when you're talking about an event afterwards and you'll say, well, this is what happened, this is what we did, they'll say, actually, we wanted to do that earlier, but we didn't know if it was right or not. And so often, actually, common sense is right. Things like they want to try and calm the patient down, they want to talk to the patient, they don't want to avoid the patient. Obviously, they have to think about safety, they have to think about distance and is there an exit and all of those things. But generally, the instinct is always to actually help the person. People don't behave like this for no reason. There's a trigger for it. And what we need to find is a trigger. It's always some unmet need. So it could be a physical need, or that unmet need could be psychological. And that's an area that we need to consider as well. You know, if somebody's in care, in hospital, they can feel very abandoned, or they could have a history of being very abandoned throughout their lives, and this is just reinforcing that. And you know, it's one way of actually getting people to take notice of you. And sometimes, you know, if you've had a very difficult life, the only way you've actually been able to get any of your needs met is by being very demanding, very aggressive, and that way people take notice of you and they help you. But the trouble is that there's always this feeling of, well, this person's attention seeking, they're being aggressive, they should be able to stop it. And actually, you know, they don't enjoy behaving like that. I would say most of the time the person is desperate to be helped, but they don't know how to ask it in the way that's socially acceptable. I think when you're presenting yourself initially in the situation, lots of people think that they should try and stop the behaviour. They think they should try and get control of the situation. And this is what often kicks things off more. So they come in and they say, so-and-so, this is unacceptable behaviour and I want you to go back to your room. Now, yes, in some circumstances, in a programme, in a treatment programme, that might be the right thing to do. But actually, we have got an urgent situation where we need to calm it down. So I would tend to go with anything the patient says. I don't argue with them. I don't confront them. Obviously, you know, if they're being dangerous to other people, you move quickly and you include security, and you're very aware that you have security as backup. And what you might have is you might have called them and they might be in the background supporting you and ready to come in if you need them. But it's mainly trying to tell people, you know, stay calm, keep a low voice, keep what we call low expressed emotion. Well, you know how normally if you meet somebody, you go, oh, hello, John, how are you today? Well, actually, even if I don't know a patient, I have very flat, I'm very flat, very submissive, and talking in quite a low tone of voice. Initially, you might have to talk quite loudly to them if they're shouting and screaming, just to get their attention. But then, as quickly as possible, you just deflate everything and you're just as quiet as possible. And if they say, you are all rubbish here, you know, the care here is rubbish, you don't say, well, no, we're doing our best. You ride with that. You ride with the insults. And then later on, you say, actually, that was quite difficult hearing that. Or you tell the patient, that's not what we're here for, basically. You can't do it in that situation because the patient can't hear you. The person can't hear you because physiologically they're so wound up that they just can't take it on board. So you do that work later. And it might be that you're having to just kind of deflect all these insults. But, you know, that's okay. You can pick that up later. You can talk about it in supervision. You know, as a team, you can talk about things and about how difficult it is sometimes. Because sometimes it's very difficult. You have somebody telling you that you're rubbish, and actually you're doing your best for them. It's very hard. So I think, you know, we always need to think about how are people going to talk about a situation afterwards? Who's going to listen to them? And even if it's just one-on-one, that is better than nothing. But, you know, obviously things like clinical supervision can be in place in some places, which is brilliant. That's really good.
Psychological formulation provides us with a conceptual framework for understanding a person's behaviour. As psychologists, we're very interested in why people do what they do. We know that all behaviour communicates something, and when there are difficulties, it's very helpful to understand what that behaviour is about. What is that behaviour communicating? Psychological formulation gives us the tools to assess and think about why somebody is behaving in the way that they're behaving, and of course that will then drive how we intervene and how we help that person. Challenging behaviour is usually underpinned by some form of distress. So it might be the case that somebody who's struggling to communicate is feeling very frustrated, they might be in pain, and their only means of talking to us is by acting in a way that they wouldn't usually behave in. So psychological formulation is all about the person. It's very specific to that person. We want to know who they are, what their background is this out of character for them, or is this something that would usually happen on a weekly basis or whatever it is. So there's a lot of information gathering from friends and relatives and carers, but also from the staff team as well that's interacting with that person, and critically from the person themselves. But as I say, often it's the case that challenging behaviour comes about due to some failure in the communication system, whether that's because the patient's unable to communicate themselves or they feel that they're not being talked to appropriately. So psychological formulation enables us to have a person-centred, individualised understanding of what it is that's distressing for that person, what it is that their behaviour communicates, and therefore what we need to do about it for them. And this is based on a number of processes and procedures, and the first step in formulation is assessment, and that involves us gathering lots and lots of information about that person, who they are, what's usual for them, what might it be about this environment particularly that's causing them to be unhappy, to be distressed. This involves, of course, talking to the person themselves, but also talking to their friends and family and gaining information about who they are, what their leisure activities are, what their job is, are they used to spending a lot of time on their own, and therefore frightened by lots of people being around them all of a sudden in a very noisy place, what their personality is and what they might normally find difficult and what they might normally find relaxing. Having that understanding will then enable us to treat them in an appropriate way. But the treatment that's derived, that's recommended, if you like, on the basis of a formulation depends on there being a whole staff team involvement and being on board with that understanding and being able to interact with that person, given that they now have this knowledge of why it is that they're behaving in the way that they're behaving. It might be that inadvertently we're maintaining the behaviour by reacting in a particular way. We might come in, lots and lots of people and start holding on to the person, which is, maybe creates more fear for them, more anxiety, and so they become even more agitated and even more aggressive. It's very important that we delineate what helps and what doesn't help, and that's what that process enables us to do. If we're able to generate a formulation of why somebody's behaving in the way that they are, and we're able to do that reasonably quickly, the main benefit, obviously, is that it's going to reduce that person's distress. It's going to enable the staff team to work more effectively with that person. It's going to enable any rehabilitation therapy input to be able to have its optimum impact on that person, to be able to engage with that therapy and any other medical conditions and treatment that might be required at that point in time. So what we want to do, obviously, is alleviate that person's distress as quickly as possible. That enables their general health care to be as effective and as swift as it possibly can be. And the end result of that, obviously, is that hopefully that person will receive the right care at the right time, and they will be able to go home if they're in a hospital setting as soon as possible.